All right, I want to welcome everyone tonight and thank you for joining us. Today is continuation in our speaker series on minority mental health because this month is National Minority Mental Health Month, and it's something that's definitely worth addressing. Tonight we have a guest with us, Dr. Angela Orvis from Rogers Behavioral Health, and she'll be giving a presentation for us tonight. So I'm going to turn it over to her and get that PowerPoint put up.
Hello, everyone. I'm Dr. Orvis. Like Nicole said, I'm a psychologist at Rogers Behavioral Health, currently working in an adolescent addiction residential program and adult depression recovery program. So today we're going to talk about BIPOC mental health, and hopefully my connections remains okay. Let me know if I get kicked out for any reason. So before I get started, I'm going to just give a super brief summary on the term BIPOC. BIPOC is a newer term that's been incorporated. It stands for Black, Indigenous, People of Color. And it's really just putting specific emphasis on individuals who are Black and Indigenous due to the extreme challenges they face over other people of color. So the intention is to uplift those voices, have better understanding and support. Next slide, please. And we're going to do a very brief land acknowledgement for the Racine-Kenosha area. So I acknowledge that the cities of Racine and Kenosha sit upon the stolen land of the Kickapoo, Peori, Potawatomi, Miamia, and the Ho-Chunk Winnebago people. So land acknowledgements are important to just be aware of, current colonization that's still going on for Indigenous folks. Take the time to learn about the experiences, past and present, of tribal nations. There's a lot of history, trauma there that really impacts mental health. Take time to support your local tribal businesses or events and just learn and support some unique cultures. Next slide, please. All right, we have a short agenda today because we only have about 45 minutes. So we're going to touch on learning about racism, impacts of racism on mental health, specific barriers for BIPOC folks when it comes to treatment, the importance of community relationships, and then some suggested readings on how to be an effective ally. Next slide, please. So what is racism? That is kind of a heavy thing to unpack, but we're going to do our best. The formal definition of racism, as identified by Merriam-Webster, is the belief that race is a fundamental determinant of human traits and capacities, and that racial differences produce an inherent superiority of particular race. So this is the white majority. Racism consists of a lot of different things, but the best way to break it down is into the broad categories of macroaggressions and microaggressions, which we're going to talk about in a little more detail. And there's also structural and systemic racism, which is a little heavier to unpack, but we'll touch on it pretty briefly. Just examples of systemic or institutionalized racism would be criminal convictions. Someone could be accused of the same crime, but the outcome and severity of consequences generally a lot more severe for people of color than white individuals. But today we're going to be talking more about microaggressions and macroaggressions. So macroaggressions are what typically comes to mind when we think about racism. They're lynchings, beatings, threatening, police brutality. Their intent is to be aggressive and to make others feel unsafe, threatened, or scared. So this can be a lot of overt threats. It can be more subtle posturing. There's a lot of things this could look like. And then there's microaggressions. Microaggressions are sometimes more subtle. They're less obvious. The intent can be veiled racism, but there often isn't a malicious intent. The racism more comes from ingrained beliefs or from a place of ignorance, not necessarily to be aggressive or to make someone feel threatened. So there's a general consensus that there are 3 types of microaggressions. There's micro insults, micro invalidations, and micro assaults. For micro insults and invalidations, they're generally more considered to be unconscious, whereas micro assaults are more of an active thought process. So an example of a micro assault would be, say you're a server at a restaurant or a bar, and it's quite crowded, and you actively choose to serve white patrons before you would serve any patrons of color. Some examples of or micro insults are more subtle disrespect towards culture or race that the speaker maybe isn't aware of or isn't even necessarily trying to do. It's more of a, like I said, a place of ignorance. So some examples of this might be when you see someone who has their hair natural or has, box braids saying, "Can I touch your hair?" or touching hair without permission. Some of this could be a cultural appropriation. We've all seen those Halloween costumes that aren't super appropriate and are pretty offensive to different cultures and ethnicities. Micro invalidations are pretty much what they sound like, right? So you're invalidating the identity and experience of a person of color. And I think the intention behind this one is to try to show support and be an ally. Some examples of this would be someone verbalizing discomfort about something someone said in a meeting, and your response is like, "Well, they didn't mean that. Like, they're not racist. They're a really good guy." Like, you're invalidating their experience and kind of what their perception of that person's message was. Another common one of this is that colorblind perspective. Like, I don't see race. We're all the human race. I don't see color. And that really sends the message of erasing and invalidating all the pain and suffering that does come with being a person of color in a majority white world. So ignoring that there's differences isn't the solution and often causes extra stress and invalidation. Next slide, please. So BIPOC outcomes. Facing daily intentional and unintentional racism can have impacts on individuals' physical and psychological well-being. And like we just talked about, there's intentional racism, and then those microaggressions are a lot of unintentional racism coming from more of a place of ignorance. I've always liked the analogy of racial impacts being similar to death by 1,000 cuts. Like, one isn't necessarily going to cause extreme distress depending on what it is. But when it's one after another in every domain of your life, like work, school, friendships, maybe romantic relationships, it really starts to take a toll and chip away at that resiliency for people. So specifically, there's also the extra stress of health disparities that minority populations face. And we're going to go over physical health, education, and then the ACEs. So physical health, in minority communities, there's often what we refer to as food deserts. There's not quality access to food, like healthy food, leafy greens, vegetables, fresh meat, and what is there is way overpriced. So people tend to then be forced into fast food diets or picking more instant, like TV dinners or ramens that aren't necessarily healthy, have high sodium content. And these poor diets, lead to worsening health, which lead to high medical costs. And Black Americans are predisposed to heart conditions. So if you combine that predisposition with unhealthy eating habits, it can have a pretty severe impact. And when your physical health is poor, it can impact your mental health for sure. And then the cost of healthcare to treat these physical ailments that can come from either those predispositions or having an unhealthy diet can lead to issues with insurance coverage. Premiums are higher, perhaps they don't have a full-time job, so they don't have insurance coverage, and that leads to avoidance of seeking out services or not being able to maintain medication compliance. So we think of the cost of insulin if you have no insurance and you compound that with the complications that would come with not taking your insulin, it just builds and builds and builds, and can lead to some pretty negative consequences. And then for education, there's access to lower quality education and less resources. Public schools generally have less rigorous standards than private schools. Budget cuts hit public schools a lot harder, and extracurricular programs are often cut. The pay for teachers is lower, so it often draws in young or inexperienced educators. And not that that's a bad thing, or necessarily young does not equate to being a poor teacher, but there's less access to those resources and how to work the system. So that's a disadvantage there. And then when we think about what goes into college acceptances these days, it's significantly more than just good grades, right? Like you have to have all these extracurriculars, a bunch of other high achieving accomplishments that some students at a public school aren't going to have access to. So if you're not in debate or on the student council and in a bunch of AP classes, your college application just doesn't have as much buffer behind it. And that can be a pretty big disadvantage. And then not getting scholarship opportunities kind of continues that cycle of lower quality education or no higher education at all, and being trapped in those low paying jobs. And then our ACEs, or adverse childhood experiences, those are certainly linked to higher mental illness, higher rates of substance use, and general health concerns. And for those of you who aren't familiar, ACEs refers to childhood traumatic events that occur between the ages of birth to 17. These can include physical abuse, sexual abuse, mental abuse, physical neglect, emotional neglect, having someone with a mental illness in the household, having a relative who's incarcerated, intimate partner violence, substance abuse in the home from a sibling, an aunt and uncle, parent, foster parent, and divorce. And people from minority populations are more at risk for acquiring a higher number of ACEs, and the more ACEs you acquire, the more severe or chronic these mental health illnesses and substance use can be. And these are just some broad examples of inherent barriers. We'll go over some more specific examples on the next couple slides. So next slides, please. Okay, so impacts of racism on mental health. We're going to go over just history in general, training, diagnosis, implicit bias, and then paranoia and fatigue. So with history, it all starts with history, right? Like we have to understand history to know where we came from and how things developed. And slavery occurred kind of in tandem with a lot of advancements in different areas, including mental and physical health. So when we consider this, it makes sense, but doesn't make it okay that some of these outdated and racist beliefs at the time have impacted the conceptualization, practice, and structure of those fields when it comes to minority treatment. And unfortunately, those racist and incorrect assumptions related to inferiority are still present today. So some of these examples are this obviously incorrect assumption that Black Americans have smaller brains, and that leads them to have lower intelligence and a preference for more manual labor. And this idea is further reinforced by just a general lack of representation in high level positions like CEOs or COOs. and more representation in physically based success like basketball or football. And this is like naturally explained away by systemic racism, low access to high quality education, and ACEs impacts. A child can be very, very bright, but if they miss school frequently because they're home watching their siblings, or they can't get a ride to school, or there's not an adult at home to wake them up on time, it's going to impact their grades. It doesn't necessarily mean they're less intelligent. There just are other things going on that distract them from that specific area. And additionally, since some public schools lack electives other than sports scholarships are sometimes people's only option for higher education. So again, that reinforces that stereotype. And similar to history, systemic racism and negative stereotyping make their way into higher education and training. So these biases that original developers had were pervasive enough to make long-standing generalizations stay in place. So when it comes to mental health specifically, BIPOC patients are less likely to receive remission from symptoms than white individuals. Practitioners also just aren't really provided training and education around specific traumas that BIPOC communities have faced. Some examples of this would be for Indigenous populations or tribal populations, the generational trauma from the boarding school era. Not a lot of people are aware of that or know about it, and it plays a huge impact into those family structures and that identity. So if we don't have an understanding of it, how can we effectively navigate some of these difficult cases we might see? And then when practitioners are ignoring or not aware of environmental factors, they may perceive patients or kids as being non-compliant or kind of resistant. So some examples of this might be having low attendance or frequent absences. There's a lot of schools or clinics that have attendance policies, and for clinics specifically, if you don't cancel your appointment within a certain amount of time, or if you have so many cancellations within a certain amount of time, you're either charged for that session or you're removed from that provider service line. And the argument generally is if your treatment or recovery is a priority, you'll make it work. And that's just not realistic for some people. If you're a single mother working 2 jobs with 4 kids and one of them gets sick unexpectedly, like, yes, your treatment is important, and taking care of your kids and making sure they have food in the house is probably going to be more of a priority. And that's not necessarily wrong. Like, people are just doing the best they can while maintaining their basic needs at the same time. Diagnosing, another area that is impacted by racism and prejudice. So when there's been studies where they kind of write up this case summary, all the symptoms are the same, the age is the same. The only thing that's different will be the race. Like maybe in one vignette, this patient is white, and in the next vignette, or it's the same vignette, but they're labeled as identified as Black. There's a wider variety of symptoms or diagnoses for the case conceptualization that is identified as Black versus the patient who's identified as white. And this is a trend that we see a lot. There's an overdiagnosis of schizophrenia in Black communities, an overdiagnosis of conduct and impulse control disorders in BIPOC communities, and an overall underdiagnosis of depression in BIPOC communities. And even when diagnoses are accurate, like I said earlier, the remission rates are lower for BIPOC individuals than for white. And I would also argue that more recently, there's a higher rate of PTSD symptoms in BIPOC communities, especially Black communities. And this makes sense with all of the police brutality and murders that have been pretty visible and in your face for the last year and a half or two, I would say. And seeing these graphic images daily does take a toll on someone's resilience. Just imagine yourself walking around every day knowing that people who look exactly like you are being murdered just because of the color of their skin. I think it would be hard to maintain that positive, upbeat attitude. And then with diagnosis, there's also a lack of consideration for cultural practices, beliefs, and norms. For example, in some Asian and Latinx cultures, it is considered pretty typical or acceptable to talk or communicate with spirits or ancestors, while in white American culture, it's often seen as a symptom of psychosis. So there's some misdiagnosis there or over pathologizing. In Latinx culture, family system is really important. And with white practitioners and white providers, is often pathologized as unhealthy enmeshment when that's kind of just the community and the culture. There's been some progress in this area with the DSM-5 having a section on cultural concepts of distress, but I don't know how many people actually are using that or looking at that. And then we have implicit bias. This picture on the slide is from Project Implicit Bias, which is a study Harvard is doing. It's a free test you can take online. You just Google Project Implicit and it takes you to the website. And you take, I don't know, it's probably like 5 minutes, clicking on your mouse when different pictures come up. And based off of that, they kind of give you a breakdown of the average person's response of if they are kind of where you're at. So for this example, this person, my screen's a little black here. There's a strong automatic preference for light skin compared to dark skin, so 27% more than the general population. A moderate automatic preference for light skin compared to dark skin. And this isn't necessarily saying whoever took this is racist. It's just all of these messages that we are shown throughout our, childhood, adulthood. It leaves these imprints on our brain and kind of how we perceive things. And the only way to kind of challenge those is to be aware of those. So I would encourage people to check it out. Do one, there's probably like 10 or so on the website from various different domains, I would say. But like I said, the only way to challenge and grow is to be aware of your blind spots. So I would encourage people to check it out. And then there's paranoia and fatigue, which we're going to talk about on the next slide. So next slide, please. So code switching, oh, sorry. Code switching was originally a sociological focus that was on alternative language or dialects. So an example would be switching from English to Spanish, otherwise known as Spanglish. It came around the 1950s. It's been updated more recently. I think in the 70s it maybe started to include adjusting aspects of one's presentation to fit in within the majority, not just on language or dialects. So the biggest example of code switching that I think people see but maybe aren't aware of is the use of African American English, also known as African American Vernacular, Standard Black English, or Ebonics. A lot of Black Americans learn to adjust away from this dialect in professional settings or in school settings or settings that are white majority in order to be seen as less threatening, more intelligent, to blend in. I mean, there could be countless reasons why. And it's unique to each individual. African American vernacular is accepted as an appropriate grammatical language. It's kind of just the standard for professionalism has been developed by white standards. So it kind of skews everything. And that's kind of just one example. There's a lot more to code switching than just language and dialect. Changing our dress, changing our mannerisms. It's very common for parents or guardians of BIPOC kids to give, quote, the talk, which is referring to essentially how to stay safe and alive when interacting with the police, or even when you're just out in the community, how to stay safe. Some examples of this would be, telling kids don't drive with loud music on, keep your hands visible at all times so you can't be seen as a threat, so people can't say you were doing something that you weren't. Present as very differential and respectful, don't be challenging, these kinds of examples. And this type of code switching can honestly be the difference between a police interaction that results in a ticket or a fine and one that could result in arrest or death. Because how you present, whether you're viewed as threatening to someone else, is what makes it a matter of life and death for some people. So being aware of code switching is important. And this switching back and forth can be confusing for some people. It can result in a lot of different emotions and anger and resentment. Anger and resentment for feeling the need to engage in this behavior, to be successful or to survive or to just fit in at work or at school. And then that's also just, there's a lot of emotional exhaustion and fatigue from constantly being on guard, having to be aware of who's around you, having to be mindful of your dialect and mannerisms. And there can also be a lot of guilt associated with code switching. Worry that you're disrespecting your race or your identity, that you're kind of selling out, letting your community down. Those are all thoughts people have and express from code switching. It's very exhausting. Next slide, please. All right, barriers to accessing treatment. Healthcare, health insurance, that's a barrier for, I think, a lot of Americans, whether they're BIPOC or not. However, the rates of insured BIPOC individuals is lower than that of white individuals. So there's an extra hurdle there. And even if someone has health insurance, that doesn't necessarily mean everything's covered. If you don't have any health insurance, the kind of strain of having to find a provider that you can afford or that's willing to work out of pocket or on a sliding fee scale. And then if you're having to also take medications, affording those without insurance coverage is a big barrier. And then access. There's a general lack of providers, especially with the wave of mental health surge with COVID over the last year and a half. The acuity that I've seen has dramatically increased. Wait lists for PHP, IOPs, outpatient providers are just pretty astronomical. And then adding on top of that, if you only have a comfort with seeing a provider of color, wow, that's going to take a long time to find some openings. And it makes sense. There are certain topics that, if your main focus is trauma from all of these, killings and murders, and you're a Black man and the only open provider is a white female, I don't know, you're going to question whether that can be a genuine connection and will be a helpful relationship for you. Stigma, there's stigma for mental health in all communities. The stigma can be worse depending on cultural acceptance and understanding of mental health. There is a lack of individuals who seek out services because the stigma of being weak like talking about Latinx culture, machismo can play a really big part with that willingness to be vulnerable, talk about their emotions, especially with a stranger, and the gender of that stranger can play into that as well. Lack of cultural training and understanding is also another barrier. Language barriers, the amount of bilingual providers, even in Spanish, is pretty low. And then when we think about, I think in Appleton or Wausau, there's a pretty large Hmong population, and the providers who are fluent in any language with that. We're seeing a lot more, refugees from the Middle East. And those language barriers are really hard to overcome, especially if you're adding on top of this a lack of healthcare, lack of access, and then just finding a provider who's competent to deal with some of those issues. And then bias, like our bias, provider bias, patient bias. We'll kind of go over some steps to address that on our next slide, please. So one way, and whether you're a practitioner, a teacher, a medical doctor, a nurse, like this is a strategy we can all utilize and help us kind of present a better picture to ourselves for the person we're working with. So the addressing model was developed by Pamela Hayes in 1996. It was updated in about 2008. And it helps, it's a tool to help focus on ensuring understanding of different facets and aspects of an individual's identity. And her theory is that gaining clarity on these 10 core domains essentially allows for a complete picture of someone's cultural identity. And those domains are on this slide here on the side. There's age and generation. And this isn't just age, it can be that. And it can also be a focus on generational status. Like is someone a first generation immigrant versus a fourth generation immigrant? Like those cultural values and norms are going to look very different. Disability is on here twice. There's a section for developmental disabilities. So, a fetal alcohol syndrome or autism spectrum, and then an acquired disability. So maybe as you got older, you were in a car accident and had a traumatic brain injury. So that would be an acquired disability. The other ones are pretty self-explanatory. National origin can also focus on native language. And then one thing I wanted to add on here was there's kind of been a push more recently, and I'm not sure where it's at currently, but to add a domain related to military and veteran status, because there is kind of a unique culture within the military system. And I think it's overlooked and not really understood. So to me, that makes a lot of sense. Next slide, please. All right, I'm going to try to pick the pace up a little bit here. So quickly, just going over racial identity development models. I have two up here for you. On the left, we have racial identity development for BIPOC folks. This specific one is based off of the Black Identity Development by William Cross. And then on the right, we have white racial identity development model based off of Helms, or developed by Helms. And kind of the takeaway from the left one, there's 5 stages: pre-encounter, encounter, immersion, immersion, internalization, and then an internalization commitment stage. And I think the important piece to point out, like there's a lot here, but for immersion, I think the one thing I would highlight is that The attitude that can best describe this stage would be the thought that all people of color are allies and all white people are the enemy or oppressor. And you kind of move through these stages back and forth. It's not necessarily a static thing. You can go from encounter to immersion to back to pre-encounter, and it's a fluid situation. And then for the white racial identity development model, there are 6 stages broken down into 2 sections, I guess, for lack of a better word. So the first 2, contact, disintegration, reintegration, they're the stages where the end goal is an abandonment of racism. Whereas the last 3 stages, pseudo-independent, immersion, autonomy, the end goal is redefining a positive white identity. And the one thing I would like to point out for these would be the reintegration stage. And that's kind of when in the disintegration stage, there's a lot of guilt and shame for being white and kind of the privilege that's associated with that. And then in reintegration, you can't really handle that cognitive dissonance of being white and not wanting to feel guilty. So it kind of turns into this spin of blaming the victim. Like, if Black people worked harder, they wouldn't be in a poorly paid position. If that person had just listened to the police, it would have been fine. And a lot of people can easily get stuck in this reintegration stage because it's hard to challenge those thoughts. And when you're in reintegration, you're not really actively seeking out diverse experiences or people. So it's really easy to stay stuck here. And that's where we're going to see more unhelpful thought process. And we can move on to the next slide, please. All right, so how to be an effective ally. It's a lot to go over in like 4 minutes, but we're gonna try our best. So the first thing you can do, really, I would say, is educate yourself. So coming to something like this, learning, challenging yourself is great. Really read and learn about white privilege. It's not a bad thing, but being aware of it is really a catalyst for change. I would recommend reading White Privilege, Unpacking the Invisible Knapsack. Like, it's very short, it's an easy read. If you are not an ally, but are more a BIPOC member, be aware of colorism, just the prejudice or discrimination for those with darker skin colors, because there is privilege that comes with being lighter skinned. So being aware of that and using your presentation to fight and advocate for those who don't have that privilege. Organization, examine where you work. Are most of your staff or colleagues white? How does your workspace show support for marginalized populations? Look at the forms you use, like, are they updated? Are they inclusive? Is the language appropriate? Look at your business policies. There's a lot of coded language in formal policies, right? Like, we just look at, a dress code, and it's mainly tailored for what's considered professionalist from a white perspective. Like, natural hair is often not seen as professional. Certain head wraps, hair wraps, indigenous headwear, they violate dress code. And there's no real reason other than, like, from a white standard, it's not considered professional. And then train your staff, hire more staff of color, advocate for more diverse hiring practices. Like, where are you posting your job positions? If you're constantly posting them in the same places, you're just going to have this same applicant pool. But if you reach out to, you know, if you're a social worker, like the, I mean, I can't speak to social workers, but for psychologies, there's the Black Psychologists Association. So posting on those types of listservs. And then next slide, please. Community involvement, just be present. You're going to be seen as a safe, supportive ally if you're in it and present and show support. Volunteer your time, money, donations, raise awareness. Like Nicole said, July is Minority and Mental Health Awareness Month. So just let your friends, family, colleagues know. Like, it takes, I don't know, 5 minutes to Google what the kind of focus of that month is, and then post a website or email a website link so people can educate themselves. Call people out or call people in when they say something that isn't appropriate. And calling people out, you want to do that when it's not acceptable and you need to prevent further harm. Where calling in is more like, oh, they're probably coming from a misunderstanding, and it allows more of a dialogue. Whereas calling people out is like, it's not acceptable. Examine your own internal bias. Like I said, that implicit bias test from Harvard is a great place to start. Research, read, listen, challenge yourself, and then be a social justice advocate or a social justice warrior. Like, you could be the most kind of educated and knowledgeable person, but if you don't do anything with it, you're not an active ally. So you gotta kind of show up and do the work. And next slide, please. All right, so suggested readings. This is kind of a busy slide. Sorry, I couldn't figure out how to make it look nicer. But these are some reading recommendations I would have. We got the classic How to Be an Anti-Racist, the new Jim Crow, Why Are All the Black Kids Sitting Together in the Cafeteria, Pedagogy of the Oppressed, Minor Feelings in Asian American Reckoning, No Human is Illegal, and then They Called Me Uncivilized. So all great options. Check them out. To take a note out of this presentation, maybe buy them from a Black-owned business instead of Amazon. I know Amazon's got some good deals, but gotta support those local community businesses. And that's all I got for you all.
I'm trying to unmute myself, sorry. Thank you so very much. I want to open the floor to anybody that has questions. Feel free to unmute yourself and ask questions, or throw them in the chat and I can read them out loud.
I just wanted to say thanks. I'm Michelle with NAMI Racine. And we actually, before I came to NAMI, I was a nurse and I taught at a nursing school, and a lot of these issues were kind of brought up. We were teaching in a really racially diverse city, but we didn't have much diversity in our faculty. And so we really worked with trying to bring in and recruit and retain more diversity, and among our student body as well, because our student body didn't have a lot of diversity at the time either, but our patients did. So do you have any, other than what you suggested, any tips for, how to appreciate the talent in our student body, or the talent in faculty, or the contributions that our employees bring, but still sort of market or want to recruit people who are diverse? Because I think so much is brought to the table with diversity, but I don't know what I'm trying to ask.
Yeah,
But
I think,
you know
I
what I
think
mean.
that's a great question, and it's a really hard one to answer. It really depends, I think, on the commitment of your organization or your, university or school that you're affiliated with. If people are kind of slapping on increasing diversity as a vague goal, but don't have active steps of how to achieve that, and they're kind of doing it just to do it because that's what everyone else is doing, it's not going to be effective, right?
Right.
So I think the best place to start is to acknowledge, like, I'm a psychologist, I don't know much about recruitment, and I would imagine, like, as a nurse, similar, you know nursing things and not necessarily marketing, which I think is why it's really helpful to get consulting firms to partner with. There's a ton in Milwaukee. Ubuntu is a great one, Black owned, and they kind of give you suggestions for how to retain and hire these, just get more diversity and representation. And if your organization is big enough, really advocate and talk about the importance of getting started in equity, diversity, and inclusion department. Because people who are trained in EDI, they know how to navigate that kind of minefield of hiring and retention and budgets and goals and all. They can kind of blend all of these things into a more realistic, attainable goal. And then if we're talking about a like student, getting more students, diverse students, think about where you're posting, think about what your scholarship opportunities are. If your school has really high tuition, there's not an opportunity for scholarships, it's going to really limit who has the privilege to attend that. So I would, those would be my initial thoughts.
Thanks. Yeah. I mean, yeah, those were lessons learned. I mean, when I was on the faculty, you're right. I think we had 95 nursing faculty, and it was always someone else in some other department who did the marketing. But now I think NAMI, we're small enough and we're centralized enough that we can make some of those decisions now. So hopefully those lessons learned will carry over to, I see several coworkers and board members on here. So take those lessons learned and bring them forward here. Thanks.
Absolutely.
I just want to share that I've taken that implicit bias test, and I consider myself to be a pretty open-minded, liberal, flowery, all of those adjectives that go with that. And I was really surprised. I was really surprised that there were some biases that I wasn't even aware of. But it was a great thing because it opened my eyes to that, So if you haven't done it, I really, really recommend it.
I agree. I also really, really recommend it. And similarly, I think my bias was, which is embarrassing to admit, but I'll share to model vulnerability. Like, because like I said, there's about 10 or so domains, and my bias was men should be the money providers and not women, which, as a high achieving professional woman, I was quite surprised. But you can't learn if you don't know.
Right. And I think a lot of it we aren't cognitive of, because a lot of it is because of the way we were raised, potentially, like with the women or the men being the breadwinner. I mean, that was the way I grew up, like that was still the norm through the 80s and 90s. Now, of course, we don't see it as much. And so I think, like my children aren't going to grow up with that bias. It'll be something completely different, I'm sure, but that won't be it. But yeah, it was a great tool.
Yeah, and it's free, so check it
Yep.
out. Spread the word, share it.
Yes. Did anyone else have any questions or comments they'd like to share?
Thank you so much, Dr. Orvis. It was a really wonderful presentation.
Yeah, of course, happy to step up and help out.
No, we really appreciate it. This is all great information to get out there. Like I said, this is being recorded. So if you know somebody who'd be interested in the information that was shared tonight, please feel free to share that. It'll be on our website tomorrow. Or you can email us and ask us for the link. All right. Well, I guess we'll wrap things up for tonight. Again, Dr. Orvis, thank you so very much. Great information, great tools. I left the pictures of the books up here in case anybody wanted to write anything down. The Unpacking the Backpack one, I've read that. That's a great book too.
Agreed. Well, I thank everyone for their time and taking their evening to challenge themselves and grow a little bit more. And it's awesome to see. Yeah, I appreciate Nami putting some stuff together.
Great. Thank you so much. Everyone have a good night.
Thank you.
And
Good
we'll
night.
see you
Thanks.
soon.
Thank you.